Hi, everyone, and thank you for joining us today. We will begin in just a few minutes as we wait for a few more people to join. Okay, I think we can get started. Hello, everyone, and welcome. My name is Eilish Hildebrand. I am the Scientific and Clinical Affairs Manager here at Response Biomedical, and I'm delighted to have you join us today. We're excited to present this webinar on quality control of point-of-care testing, led by Dr. James Nichols. Dr. Nichols is a recognized leader in clinical chemistry and point-of-care testing, and we're grateful he's here to share his experience. Next slide, please. Before we begin, I'd like to give you a brief overview of Response Biomedical. We are a Canadian diagnostic company headquartered in Vancouver and provide acute care diagnostic tests, specializing in rapid lab quality immunoassays for critical conditions. Our RAMP platform, which is the analyzer that we manufacture, enables fast, reliable results from whole blood samples. Quality is, of course, central to what we do. We operate under MDSAP and ISO 13485, and our products are used globally, including FDA-cleared cardiac tests. Next slide, please. So here's just a quick look at how today's session will run. The webinar will be about 40 minutes, followed by a 10-minute Q&A session. If you have questions at any point, please type them into the Q&A box. We'll collect them throughout the talk, and at the end, both Response Biomedical and Dr. Nichols will address as many as we can. And please note that this webinar will be recorded, and if you are interested in accessing the recording, it will be available on our YouTube channel in the coming days. Next slide, please. Okay, now I'd like to formally introduce our speaker. Dr. James Nichols is a leading clinical chemist and professor at Vanderbilt University Medical Center, where he directs clinical chemistry and point-of-care testing. He trained at UC San Diego, the University of Illinois, and the Mayo Clinic, and is board certified in both clinical and toxicological chemistry. He has held major roles at Johns Hopkins, Bay State Health, and Tufts University, and his work focuses on evidence-based practice, POCT, automation, and toxicology. We're very fortunate to have him with us today, and with that, I will turn it over to Dr. Nichols.
Thank you for that introduction. As mentioned, I'm going to talk about quality control of point-of-care testing. We're going to define point-of-care testing, identify challenges of controlling point-of-care quality, describe some common sources of laboratory error, and adopt a risk management approach to ensuring test quality. Now, point-of-care is clinical laboratory testing conducted close to the site of patient care. It's typically by clinical personnel or non-laboratory med techs and medical laboratory scientists. Point-of-care really refers to any test performed outside of the traditional core or central laboratory. It is a popular means and really growing in popularity because it has great potential. You get immediate results with no lab transportation of specimens on portable devices using small capillary or native samples like urine, swabs. A wide menu of tests are available. and it works within the clinical patient flow. While the clinician is seeing the patient, they can order a test, collect a specimen, the test is run, they get results while the patient is still in the physician office or at the patient's bedside. There's the opportunity then for improved patient outcome when we link the point of care results to treatment and immediate action. Here's just a partial point of care testing menu in the United States. We have obviously diabetes, anemia markers like hemoglobin hematocrit, infection or chronic infections for SED rates, CRP. We also have fertility testing, urine and kidney function tests like microalbumin, creatinine ratios, infectious disease and sexually transmitted infections, occult blood, bacterial vaginosis, drugs of abuse, and some therapeutic drug monitoring, as well as liver function testing and lipids, cardiac function testing, a coag test, and even some tumor markers. Now, quality in the lab, clinicians really rely on laboratory results for medical decision making. Quality is an essential component of laboratory testing, and errors in laboratory results can lead to misdiagnosis, medical mismanagement, and really increased overall cost of care. Point of care is simply an extension of the laboratory, only moving that lab closer to the patient. Point of care requires the same quality, though, as all other laboratory tests. And quality control, as you'll see in this talk, is really only one means to ensuring quality of laboratory and point of care testing. Some definitions up front. Quality assurance is the overall umbrella of all of the things that we do, pre-analytic, analytic, and post-analytic, to promote excellent outcomes in patient care. Quality control is one part of this total quality assurance umbrella, and it's an integral component of quality assurance and the aggregate of processes and techniques to detect, reduce, or correct deficiencies, primarily in the analytical phase of testing. Quality improvement is the practice of continuously assessing our benchmarks of quality and outcomes and adjusting performance to improve performance over time. Our laboratories are actual modern factories. Just like the industrial factories, our analyzers basically have track systems to move samples around between analyzers and conduct things in an automated fashion. So historical quality control in the laboratory was born from the 1900s factory or industrial model of quality in the analytical process. We're in the factory. The product is periodically inspected on the line as cars are being put together, as other products are being put together, and they're looking for meeting specifications at that step of the process. So quality control in the lab is a stabilized surrogate sample. It's analyzed like a patient sample and contains a known amount of measured analyte. So if the analytical system can achieve that desired result within the errors of performance using a QC sample, then we know that the system is stable and quality patient results are being produced. ISO 15189 indicates that the laboratory should design a quality control procedure that verifies the attainment of the intended quality of results. The laboratory shall have a procedure to prevent the release of patient results, in other words, stop the line of testing in the event of a quality control failure. And when quality control rules are violated and indicate that examination results are likely to contain clinically significant errors, those results should be rejected and relevant patient samples re-examined after the error condition's been corrected. So quality control data should be reviewed periodically to detect trends in the analytical or examination phase that may indicate problems, and when such trends are noted, preventative action should be taken and recorded. This is the overall sequence of events that can create risk of harm to a patient. We have an initiating cause that can lead to a testing process failure that then leads to incorrect result generation, incorrect results being reported that could lead to misdiagnosis and present a hazardous medical action where the patient is harmed. And between each of these steps, we have a probability, P1, P2, P3, and so forth, that can create this hazardous situation. So our laboratory quality control is really intended to detect failures in the testing process and detect and correct errors before they leave the laboratory, and a hazardous situation is created. So the goal of QC is to detect and prevent erroneous results from reaching the patient. And our optimum QC strategy maximizes error detection while minimizing false rejection. In other words, it balances risk with clinical tolerance. ISO QC also recommends that the laboratory shall use quality control materials that react to the examining system in a manner as close as possible as patient samples, and that these QC materials shall be periodically examined at a frequency that's based on the stability of the procedure and the risk of harm to the patient from an erroneous result. So the latest ISO guidelines actually have incorporated that industrial risk assessment. Now, many factors can cause errors in test results. They can come from reagent degradation, calibrator control storage, failure of the instrumentation itself, as well as incorrect operation or calibration and inadvertent mistakes from operators or personnel. There are two primary types of errors. A systematic error, this leads to bias from one point forward for a period of time. Could be a problem with calibration, standards, reagents, blanks, controls. In other words, the bias we're seeing on the control sample mimics the bias that we're going to be seeing with patient results. Random errors, however, are much more insidious. They occur with a single sample and are not persistent. They can occur because of a clot, a bubble, drug interferences, or even hemolysis in a single sample. It's way easier to detect systematic errors with quality control solutions because they're persistent rather than random errors. We plot quality control results over time, and oftentimes we'll use a Lovey-Jennings chart like this to look for shifts and trends in performance. Our traditional quality control rules, after assessing and setting a mean and standard deviation, look in future ongoing performance using multi-rules like 1-2S, where 1 point is outside of 2 standard deviations, 1-3S rules outside of 3 standard deviations, and a variety of other rules. The selection of the rules will depend on the quality goals desired and the level of method performance. You may have seen the multi-rule Shewhart procedure that was published in Westgard's rules that many core laboratories utilize. Now, quality control, I mentioned, is the stabilized surrogate sample of known concentration, analyzed like a patient sample to determine assay recovery and result stability over time. It has advantages because it has target values, and if the assay recovers the target, then everything with the system is assumed to be stable. QC monitors the end product, the result of the entire test system, that instrument, the reagent, the operator, the sample. The disadvantages are with our modern factory-like analyzers is that we only analyze QC periodically. If we release results before the next QC is run, we could release erroneous results. Then clinical action could be taken on those results before we realize at the next QC performance that we have a system problem. CLIA 88 in the United States requires a minimum of 2 levels of quality control each day of testing for every test that's performed. Periodic QC works well for these automated analyzers, but QC is challenging for point of care testing. That's because on our laboratory analyzers, we have bottles of liquid reagent that perform dozens, hundreds, even thousands of tests over a period of weeks or days. And so we're sampling from that reagent bottle and looking at drift over time. But point of care is mostly unit use strips, cartridges, and cassettes. They perform a single test. So when we run quality control, we consume that entire test, and QC on that test isn't guaranteed that QC on the next test strip is going to be comparable. Fortunately, manufacturers have built-in electronic controls and onboard chemical and biological controls in the newer point of care testing devices. Many of these tests have manufacturer control processes and procedures. And some of these tests, like non-invasive bilirubin, for instance, you can't even run a quality control on in a traditional liquid QC fashion. So there are onboard and analyzer QC built into the device controls. We have the option of running internal QC. In the international language, this would be laboratory analyzed surrogate sample QC controls. We can subscribe to external quality control programs, our blind proficiency surveys, but there's a variety of other quality control processes that are either engineered by the manufacturer or enacted by the laboratory to ensure result reliability. Give you an example. Many of our reagents are being packaged with a temperature stability control paper or cartridge in the shipping carton. This is because the manufacturer can guarantee the quality of their results when they leave the plant, but they don't know what temperature and conditions they're going to be subjected to in transit to the receiving laboratory or hospital. So when we receive a new shipment, we open up that package, and in the bottom, many manufacturers are now including a test strip or a cartridge that if it freezes, it will crush and burst a little vial that puts a red dye within the bottom of the package, the cold package. Others, actually, for overheating, have a temperature paper that will change color if it's outside of manufacturer's specifications. This saves us as the receiving laboratory from labor in checking the quality of these products and expending a lot of resources doing that, where if we see it's compromised in shipment, we can return the reagents and get a new shipment that may not be compromised. So I will say that quality control and building a good quality control plan is a laboratory manufacturer partnership. There is no single quality control procedure that can cover all devices because all of our point of care devices differ. Developing a quality control plan or strategy surrounding point of care requires this partnership. Some sources of error, the temperature, for instance, may be detected automatically by the device and prevented. Others may require the laboratory to take action, training, maintenance, competency checks of the operators, or analyzing surrogate sample QC on receipt of new lots of reagents. So clear communication of potential sources of error and delineation of laboratory and manufacturer roles for how to detect and prevent those risks is really necessary. There is no perfect device. I think we all realize that. Otherwise, we'd all be using that device. Any device can and will fail if it's run under the right conditions, or what I would consider conditions outside of manufacturer specifications. So any discussion of risk has to start with what can go wrong with the test. Tests are not foolproof, and this is something that clinicians at the point of care may not necessarily realize. Excuse me. So with point of care testing, the complexities are because we have dozens of sites, hundreds of devices, and thousands of operators within an institution. It's like having too many cooks spoiling the broth. The number of sites, devices, Clinical and non-laboratory operators, plus the volume of testing that's being conducted, creates a situation where even rare events can be probable everyday operations. I like this phrase attributed to one of my distinguished colleagues. She said, "Nothing is foolproof for a sufficiently talented fool." So even though we have manufacturer checks and balances in many of our devices, operators are very smart, and oftentimes they will figure ways to get around those operator lockouts, QC lockouts, and other features that are intended to document the quality of the laboratory test. Now, manufacturers consider the potential for errors and address these hazards and how these hazards are mitigated or reduced in their Food and Drug Administration submissions in the United States based on use case scenarios. Use case scenarios is a real world example of how one or more people interact with the device. Take an example of a point of care device. We have a couple of options. We can take the device to the patient's bedside, collect the sample there, and actually run it at the bedside. Or we can collect a sample, we can take it down the hall where the device stays in a dirty utility room, and then do the testing in that room. These have two different scenarios for, just take for instance, the risk of mislabeling a sample. If we take the device to the patient, collect the sample, and run the test at the patient's bedside, we have very little risk of mislabeling and misidentifying that test result. However, if we collect a sample, take it down the hall, now we have an increased probability that that sample could be interchanged with the sample from another patient. So proper labeling becomes much more important in that use case. This really brings me to the Clinical and Laboratory Standards Institute, EP23, which is laboratory quality control based on risk management. This document describes good laboratory practice for developing a quality control plan based on manufacturer's information, applicable regulatory and accreditation requirements, and the individual healthcare and laboratory setting. Basically, we take information about the test, the medical requirements, why and how is the clinician utilizing that test result and ordering the test in the first place, the local regulatory and accreditation requirements, as well as test system information, that provided by the manufacturer, as well as that obtained by the laboratory, maybe talking with colleagues who are using the same device, and information about the healthcare setting and test site setting. For instance, a point of care test conducted within a hospital has well-controlled temperature and humidity, as opposed to taking that device outside to a community clinic or visiting nurses that are going to the patient's homes. Now the device and the test strips and controls may be exposed to extremes of temperature, heat, humidity. We process that information through a risk assessment. And then, based on the risks and how we're going to address and mitigate those risks, we outline and define a quality control plan. That after we implement that plan, through continuous improvement, we monitor for continued errors and modify our quality control plan based on new assessment of risk. Essentially, we are tracking the sample like the patient sample. So we create a process map from pre-analytic to analytic to post-analytic, from order to sample collection to analysis to reporting of results and taking action. And at each step of that process, we identify weaknesses, conditions where that might present risk to the patient or of an erroneous result. We define then a process that will mitigate each of those risks, and that's summarized as our quality control plan. We have to consider pre-analytic, analytic, and post-analytic processes, as well as conditions that may affect test results from samples, from the operator, from the reagents, the laboratory environment, and the measuring system, amongst others, depending on the device. And once we identify the risks, we need to detect and prevent those errors from harming the patient. So control processes reduce risk by enhancing the detection of errors and limiting harm if the errors go undetected. A control process can take many forms, from liquid QC to engineered checks within the device. Give you an example. One of the institutions, the unit was an ICU. We got a complaint of a sporadic falsely decreased glucose test result. Immediately upon repeating the test on the same meter, gave significantly higher, what the staff described as clinically sensible values. So we sent our point of care staff up to the unit, and they found that the nurses were taking procedural shortcuts to save time. In essence, they were trained that when you open a new bottle of glucose test strips, you should remove just one test strip to conduct the test and keep the cap tightly capped to prevent air from going in and altering the chemicals on the test strip. Those chemicals are very hygroscopic, and in humid environments, they can absorb water. Unfortunately, the type of strip that we were using and the way that it was manufactured, the manufacturer had created a narrow opening on the neck of the bottle to prevent air exchange and minimize air exchange. However, that neck was very narrow and too narrow for a lot of the nurses with gloved hands to reach in and get a test strip out, just one test strip. So instead of doing what they were trained, they wanted to get back to their patient care. That's what valued, and that's what their primary purpose was, caring for the patient, not doing laboratory testing. So they took shortcuts. When they opened the bottle for the first time, they would dump the entire bottle of test strips on an absorbent mat and then pick up one of the strips, which was easier, off the mat and do the test. When they were done with the test, they would toss the test strip in the trash can at the end of the counter. Sometimes the test strip made it into the trash can, other times it made it back onto the mat. And the next person who came by reused that test strip. So, unfortunately, what we discovered is that some devices can detect a used strip while others do not. So the next glucose meter, when the contract was up, we went to one that detected that type of error and prevented reuse. We also had to retrain all of the staff on the risks of reusing this and keeping the test strips exposed to air. The Center for Disease Control and the FDA in the United States have also sent out recommendations to make sure that operators are checking for expired reagents. Um, Test strips, like glucose test strips and controls, have imprinted manufacturer expiration dates on the outside. But many point of care devices, once you open that bottle, controls or test strips, they prematurely expire because of exposure to air 30, 60, or 90 days after opening. So the operators, every time they do a test, should check the manufacturer's expiration date and make sure that the vials and controls have been manually redated to the new expiration date. This shows one institution who confiscated those bottles that did not have updating when opening the bottles, just to show strip wastage and what can happen in terms of resources from this whole manipulation of premature expiration versus manufacturer expiration. Fortunately, newer devices and manufacturers have actually created either individually wrapped test strips that are good to the manufacturer's expiration date, or they have serialized vials. In other words, vial A within the lot, vial B within that lot, that the first time that vial is scanned, it's assumed that that bottle's been opened and is being used. And within the software system of the point of care device, it starts a countdown of 30, 60, or 90 days based on that expiration and will prevent patient testing on that bottle of test strips if it goes past that open expiration date. This is just an example of an individualized quality control plan. Remember, there are three parts. There is the risk assessment, there is the quality control plan, and then the quality assessment once you implement this, periodically looking for continued errors and reassessing risk. Those three components create our individualized quality control plan. I show some pre-analytic issues that can occur that we need really consideration for all of our lab tests, not just point of care tests. Is there adequate sample in the right tube additive? Has it been well mixed and labeled properly? Clots, these may be due to a delay in mixing and delay of analysis if there's no additives. Bubbles that are produced during transfer to either a test strip or a cartridge. The potential for drug interferences and documentation. Where is the documentation of issues when the operator who collected or the phlebotomist, where did they document that in the charts and how does that get linked to the test result? Now, some point of care analyzers are starting to integrate artificial intelligence. They can monitor the sample quality, detect common operator errors and interferences. I'll mention one of these, hemolysis. This is the number one source of pre-analytic errors for many different types of tests. Approximately 1 in 5 samples are hemolyzed in the emergency departments, and nearly half are hemolyzed or up to half in the neonatal intensive care units for fragile newborns. Hemolysis elevates potassium, and it can elevate it well over 100, 150%, depending on the amount of hemolysis. That in vitro hemolysis can lead to inappropriate patient management, decreased patient satisfaction due to delays and need for recollects that then cause increased cost and insufficient staff and nursing resource management. In the laboratory, on every sample that goes through our automated chemistry platforms, we perform a hemolysis index. We do a dilution of the sample into normal saline. We shine light onto the sample, and we look for the degree of redness of that sample. And we can actually grade it as 1 plus, 2 plus, 3 plus, 4 plus, or higher visually, or get a semi-quantitative or quantitative analysis from that hemolysis index, which then, based on the level of hemolysis, we can append a comment to that test result that either indicates it's mild, moderate, or grossly hemolyzed. And most laboratories do convert hemolysis, icterus, and lipemia indices to a comment that's appended. And I mentioned about the moderate, or gross hemolysis. So here's our scales, and you can see the absorption spectra, wavelengths of light versus the amount of absorption. And the spectra for hemolysis, icterus, and lipemia usually is out in the 600 wavelengths. But point of care. Point of care, we use unprocessed samples. We don't see serum or plasma. All we see is red because it's a whole blood sample. Most clinicians realize they're familiar getting mild, moderate, gross hemolysis comments with their chemistry lab results, but they don't realize that they're not receiving that with point of care platforms. And the current practice is to rely on imprecise clinical judgment based on the level of potassium, or wait on a recollect from the central laboratory and redraw and retest at that point. Just to indicate the level of hemolysis from different nursing units, we worked with Hennepin County up in Minneapolis and Fred Apple. And we took blood gas samples that were coming into the laboratory, spun down each of the blood gas samples, and ran a hemolysis index on them on our automated chemistry platform. We then also ran potassium levels on each of these samples and looked at the levels of hemolysis versus the amount of potassium. And you can see that the hemolysis occurs in all of the different nursing units, some higher than others, like the emergency room and our burn units. What was very interesting was that we expect, or suspect actually, that a high potassium greater than 5 is hemolyzed. And in fact, in the emergency department, we noted about 62.5% of results with potassiums greater than 5 were actually hemolyzed. But what we didn't realize is a significant portion, 10 to 17% of potassiums in the normal and even hypokalemic range are hemolyzed. That presents a risk of mistreating the patient and not realizing that they may actually be hypokalemic and hemolyzed, even more severely hypokalemic than we would expect. Same in the ICU, as much as 41% for elevated potassiums, but a good portion, 3 to 5% in the low to normal range. That would mask hypokalemia. Fortunately, there are newer point of care testing devices. A new blood gas analyzer was introduced last year that has an optical flow cell. This as the whole blood sample passes through this flow cell, it is impeded with acoustic wavelengths or sound waves. Those sound waves move the cells to the side of the chamber and allow light to shine through the cleared plasma. And much like we do in the main chemistry laboratory, on this analyzer, we're able to get a hemolysis index that can then be converted to a comment and appended to the result or alerted to the operator. This is actually how it works. It's a rather unique engineering. You can see at 0, you have the whole blood sample coming through that flow cell. And as the sound waves are shot across that flow cell, you can start to see the red blood cells moving to the side of the chamber, where the center of the chamber actually stays clear, and we can get a plasma-free hemoglobin measurement or hemolysis index. What it looks like to the operator, it's dependent on how the institution sets this up, but they can mimic very similarly the level of hemolysis with the same comments that the chemistry laboratory uses. So now we have both point of care covered as well as the chemistry laboratory for potassium results. And you can see the little red drop here next to the potassium indicates, even though it's in the normal range, that this is a moderately hemolyzed sample. And you can configure, it's purely by the customer and the laboratory, you can configure these and the comments to match what the central core laboratory is doing. So with that, I'd like to summarize and say that quality control for point of care testing is challenging. It's challenging because it doesn't use bulk reagents like the chemistry platforms. It uses unit use, single use cartridges and test strips. 2 levels of liquid quality control are required each day of testing for unit use point of care. That may be redundant to what the manufacturers actually built into and engineered into the system. Risk management can assess workflow for weak steps, hazards, and risks of an erroneous result, and help develop an individualized quality control plan of mitigation steps that the laboratory can implement to basically mitigate the risk of an erroneous result. IQCPs, these individualized quality control plans, are more than just reducing the frequency of liquid QC. They are finding the right QC for that device and that location. They provide an opportunity for laboratories to interact directly with the clinical departments on a shared quality improvement project, helps improve workflow, operational efficiency, and it's important to realize that our newer point of care devices, manufacturers are engineering control processes to better detect common sources of error, like I mentioned, the hemolysis in the blood gas platform. So with that, I am going to turn it back over to Eilish, our moderator, And I want to thank you for your attention and open up for questions.
Thank you very much, Dr. Nichols. That was an amazing presentation. We do have some questions here. The first one is, why should we run liquid QC on a POCT device when the onboard QC already passes, especially since each liquid QC run only tells us about one single-use test cartridge? What's the point or what benefit does it provide?
Yeah, so I can say that this is quite the reason why we started with the risk management and the
Mhm.
development of IQCPs to find that right balance. Because if we have to run two levels of liquid QC on cartridges that basically consume that test and don't guarantee the next cartridge is comparable quality, and the manufacturer already has this QC built in, it is very redundant. So I think as you look to what can go wrong with that test, how is it being used by clinicians? What setting is it being used in? We can find that right balance of liquid QC. Maybe doesn't need to be done daily because we're going to rely more on that built-in QC that's in every test on a daily basis, on an every test basis, rather than using that liquid QC and reserving it for check-ins of new shipments, maybe periodically as it's sitting on the shelf to make sure that the chemicals are still viable. So that individualized quality control plan really is a balance between liquid QC, too much of it, and how we're going to balance that with the manufacturer QC.
Perfect. Thank you so much. The next question is, how can labs better partner with clinical staff to ensure procedural adherences in fast-paced environments like the ED or ICU, NICU? And what strategies have been most effective in reducing operator-driven errors?
So the most effective are training
Mhm.
and ongoing competency checks. I would say that's the number one to mitigate, problems. But areas that have high staff turnover, like the emergency room, because you have a lot of float staff, they're there temporarily, they may work in other areas of the hospital. Those are prone to more uh, erroneous results, to problems. And in those areas, I think laboratories, hospitals need to take extra steps.
Mm.
Maybe find a champion, a nurse supervisor on that floor that can help coordinate and challenge the staff to get the right results.
Perfect. Thank you. The next question is, what is the best material for POCT QC, and what is your recommendation for external QC?
Sure. So I think the best material depends on your device, obviously. Not all QC is amenable to all devices, particularly when we start to talk about whole blood samples. iStats and other types of devices, universally, you can't cross different manufacturers, and not all controls are amenable to all devices. So find the best QC for that particular test that I would say mimics a patient sample,
Mm.
comparable types of problems you would have. What's the recommended frequency or whatever would depend on your individualized quality control plan.
Okay,
And the
great.
minimum recommendations from the manufacturer. Manufacturer tells you you have to run QC at least once a week, then you can't go less than once a week.
Okay, perfect. Um, how would an increase in potassium as a result of hemolysis in a blood sample affect an immunoassay?
It can affect different tests in different ways. I know that on our immunoassay platforms in our chemistry lab, we have a big problem that small amounts of hemolysis can cause wide variations in interference. So I would say be careful. Look at the analyzer yourself and look at the package insert because all manufacturers, particularly for hemolysis, have actually um, done some interference studies, and they'll show at what level of hemolysis this particular test or platform is impacted.
And kind of in the similar topic, are you aware of literature that assesses physicians and other caregivers' understanding of clinical impact of hemolysis? Uh, that we work hard to identify and comment on it, but how do we know what they do with this information?
I
Or
think
do we
that's a
know?
great question. We don't exactly know their level of knowledge, and it would be a great study.
Mhm. Okay. Next question is, I use a urine dipstick reader. Do I have to QC both the test strips as well as the readers if I have multiple readers in use?
I would say you have to assess the chemistry, which is in the test strips themselves. A reader is just basically a voltage meter or a spectrophotometer. It's looking colorimetrically at the change in the color on that dipstick. But uh, we have internal calibrations and everything from the manufacturer, looking at the light source, looking at the electrical current, looking at all of the spectrophotometry going on with the reader at power up. That is the same with each and every device, provided it's working well. But on the other side, we don't know on the chemistries, and particularly if their dipsticks are exposed to air, if they're exposed to humid environment, they may go bad. So that's why it's important to pick the lot of test strips that you have open and match it with a subset, I would say, of urine dipsticks. But that would depend on your laboratory director, and it really needs to be integrated into your individualized quality control plan.
Great. Next question is, what is the best way if we have different reference ranges for some tests based on the area or human culture? For example, G6PD. Best way to
So I
establish the referencing? Go ahead, sorry.
Yeah, I would say, there are some ethnic differences in terms of different reference ranges. I would make sure that in the region, the site that you are actually performing the test, that the verification studies are looking at that reference interval and making sure that it matches sort of a universal. Otherwise, it has to be modified based on where that test is being performed.
Mhm. Mhm.
The typical population.
Right. Okay, perfect. And if your nursing staff doesn't want to analyze QC because they claim this is a lab responsibility, is it okay for the POCT staff to do the QC instead of the nursing staff?
This really is a no-no, I would say. The intent of quality control is to look at the entire system. That would be the test instrument, the chemistry of the reagent, the environment that it's been stored in, and most importantly, the operator. And it's important that operators that are doing the test in routine are the same that are doing the quality control. It assesses their performance.
Mm, okay, perfect. This next question is, did you recommend the coloration factor if there is variation on the QC result from device to device?
I am taking this to ask, should you change the QC ranges based on the device, um, if there's variation in the results from device to device? I would ask the bigger question, why are you seeing that type of variation?
Mm,
So your quality control ranges should cover all devices based on the lot of the quality control that you're using. If you are trying to make it that tight to look to one device versus a different device, beyond driving the operators crazy and trying to figure out what's passed, what's failed, I think you should look at why is there that much variation. Otherwise, if it's just tiny variation, pick a range that encompasses all devices for a given lot of test strips or
mhm.
QC.
Um, We have time for a few more questions, if that's okay.
Sure.
Um, Given the shift from a traditional QC to risk-based IQCPs, what do you think is the most common misunderstanding labs have when implementing an IQCP?
So I think in the United States, many of the Joint Commission, the College of American Pathologists, even the state Department of Health, CMS, has said that IQCPs are really for moderate complexity tests. But IQCPs can be applied to wave tests as well as, most importantly, lab developed tests to select the right frequency of QC.
And I think maybe this will be our last question, but is there any daily or periodic QC that's appropriate for lateral flow tests like pregnancy kits? Do you recommend daily external QCs per lot or based on risk?
Number one, I think it's risk-based for your site, depending on your operators. And let's take pregnancy tests, for instance, which have a built-in positive as well as the clearing the white background is your negative control. So even though each test has that built-in control, you still need to make sure as you're storing those test strips or cartridges for pregnancy on the shelf that not just that monitoring for temperature and humidity, but also for viability of the chemistry of the reaction. And that's why periodic positive and negative quality control urine samples would be important at least on a monthly basis, I would think. But that depends on the site and depends on your IQCP. But certainly, doing quality control to prove that a shipment is viable before you use it for patient testing when you receive new shipments, even if it's the same lot number, would be important. If you shift lot numbers, that would be important as well to cover and make sure your QC is covering all the lots you have with possible use on patients.
Amazing. Thank you. Okay, so I think that is all of our questions, and we can close off this webinar for today. But thank you so much for your very interesting presentation and for answering all of those questions, Dr. Nichols. And to all of the participants here today, thank you for attending.
Well, thank you.
Oh, great. Well, everyone have a great day. Goodbye.